Good evening, everyone. I'd like to welcome you to the Imperial College Master of Research in Medical Device Design and Entrepreneurship in elevator pitch event for 2021. We're disappointed that you can't be here in person, but we have a small gathering in the room here, very large room, small gathering, so we're all safe and maintaining our distance and wearing masks. Nevertheless, this is an exciting event for the students and something they look forward to every year. I'm Professor James Moore. I've run this program for the past 8 years. It's really a joy to run this program. We've had several spin-outs come from the master's program where the students actually go in and form the companies that they wrote about in their thesis. And we're very proud of those, but most of all, we're proud of the students themselves. The real product of this master's program is not the spin-outs, it's not the technologies, it's the students. And they go on and do wonderful things after they graduate, and we're very proud of them and their accomplishments. One of the people that helps me a lot with this program is here this evening, Danny Green. He is a serial entrepreneur and a just wonderful real-world case study for the students and role model for the students. And we're so proud of him and all of his accomplishments and what he brings to the program. So I want to acknowledge Danny for his contributions, really just invaluable to the program. We have an expert panel here this evening to ask a couple of questions after each pitch. So I'd like to introduce them. So we won't be taking questions from the audience, just to clarify. So please, I don't know if we have any access to a chat here, but if you type things into the chat, we'll try to get back to you eventually. But there will be an opportunity for interaction with the students individually afterwards, and we'll put up a quick response code and a web link for that at the end of the event. So you can go directly from the event then to the interaction with the students. Now on to our panel. We have on our panel connected remotely is Rowan Gardner, and I will dig out her, you have to pardon me, I had this ready, but then I had to go and answer something else. So Rowan, maybe it's good if you just introduce yourself. Sorry, we're improvising this evening, aren't we?
Hello everyone. When I'm not an 18-foot image appearing on the wall of a room in Imperial, I'm a serial entrepreneur, so I've walked in your steps. I've raised capital for businesses that I've been CEO of. I'm a founder of several companies involved in informatics, medtech, AI, and I'm currently a non-exec director of Digital Health and Care Wales, which is a new special health authority in Wales charged with the delivery of digital health and care. And I'm also a juror for the Cartier Women's Initiative, which awards an annual prize for science and technology pioneers every year. Our award ceremony was yesterday. So I'm very supportive of your endeavours. I'm really looking forward to your pitches. So enough about me.
Excellent. Thank you, Rowan. Thanks for your flexibility there. The second member of our panel this evening is Professor Kevin Moore, no relation, from UCL, University College London. He's a professor of hepatology and pharmacology. He leads the UCL Therapeutics teaching program for their medical students and also leads the Applied Medical Sciences program at UCL, and currently has his own startup in digital health. So you can see we've got a good mixture of entrepreneurship and medical background and real-world experience in all of this. And I know they'll be asking our students some very, hopefully somewhat challenging questions, but certainly very informed questions about the pathway ahead not only for these technologies, but for the students as well. So without further delay, we'd like to bring up the students. So our first student today is, come on up, is Antonia Beidenharn.
Once I asked a friend of mine how her skin disease feels like. And she told me it's like constantly falling into stinging nettles. You feel itchy and you're covered in red rashes. This is the brutal reality of people with a skin disease eczema. This is reality for every 7th person in this room. My friend and substantially all eczema patients struggle to determine how long their rashes last, what they're caused by, and what helps to treat them. Also, if you'd ask eczema patients what they believe will improve their quality of life the most, 75% will answer the control of their condition. This is why we want to enable eczema patients to control their condition and to improve their health and well-being. To do that in an easy and mobile way, we've developed an AI eczema app together with experts from Imperial College London. Patients monitor their eczema with our app, which warns them if a flare-up is approaching and recommends treatment to mitigate the condition. We predict that our app cuts the time people are in eczema flare-up in half. We also believe that we can capture a serviceable, available market of 7 million patients in the US and Europe. We're looking for 800,000 euros to complete preclinical trials. My name is Antonia, and let's kill the stinging nettles of eczema patients together. Thank you, and I'm looking forward to talking to you.
Kevin, would you like to go next?
Yes, thank you very much. Very interesting. I'm just trying, can you just explain a little bit more? Because really, to be effective, you've got, the people using the app have got to identify symptoms that are predictive of an eczema flare before the eczema flare develops. So presumably you've got to develop some data in patients who develop flares, which gives you your background cohort to analyze using machine learning. And then using that, you want to show that you can predict. Do you actually have any data to show that, and what sort of symptoms or what sort of aggregate data do you put together to predict? It's a very long-winded question, so I apologize for not being brief.
Do you mean what data set, if we have a data set with which we train our machine learning models? Is that your question, or are you asking for our clinical
Most
outcomes?
people know when they've got eczema. They know that they've got a rash. They know that it itches. What is it that you're identifying that would predict when at the early stages of eczema, when early treatment halves the duration of the attack?
So this is going to be done by a machine learning model, which we call eczema Pret. And basically, you'll give the machine learning model an eczema severity, and then the model will predict what your eczema severity is going to be in a day or a week, for example.
Okay.
Does that answer your question?
Yes, it does. So it's okay. And so at the moment, you don't have any of that data. It's just the idea is that you're going to take a cohort of patients with eczema and look at that data and then analyze it and see what factors come out in the wash. We
do have the training data set, which we use to train the machine learning model, so that does exist.
Okay.
Yeah.
And what factors are you going to use to predict? Because so being able to predict is the bit I'm finding difficult to understand.
Okay, so we're using eczema severity scores. So they're like different verified eczema severity scores, and we're going to base that on that.
Okay.
All right, Roland.
Thank you, Tony. That's really interesting. So in Digital Health Wales, there's a national strategy called the Healthier Wales, and we're really looking for tools that will help patients control their health and manage their conditions more effectively. That said, although we've got these strategies in place, it's much harder to actually deploy them. And I wondered, with your idea and model, who do you see paying for this service?
Yes, so we think there are two ways for us to get reimbursed. So we think there's a B2B opportunity and a B2C opportunity. So B2C, and both times in form of subscriptions. So B2C opportunity would be to sell to our end consumers directly, which would be patients or caregivers. And so to give you a number, most of eczema apps are reimbursed at a price of like 10 to 20 euros. And then our C2C opportunity, B2B opportunity, I think would be to get our app reimbursed by healthcare insurances. And there's actually one eczema app out there which is reimbursed by 4 German healthcare insurances at a price of 50 euros a month. So we think that would be 2 good ways for us to go.
And I think Kevin talked a little bit about your model, but there is this increased interest in regulating AI-driven models in healthcare. And for clinicians to feel comfortable recommending these types of tools to their patients, they want to see it has explainability. You know, you can explain how your model informs the activity that you are encouraging people to take. So what are your plans in your trials to actually get that evidence as well as the general predictability?
Yes, so we're definitely going to perform clinical trials to show that we have positive outcomes. We think that the outcomes we're expecting, or we want to show, is that we can increase the quality of life for patients as well as for caregivers, because they also suffer under the eczema of the person they're taking care of. We also want to show that we can reduce eczema flare-up, the number of eczema flare-up a patient has. And then we also want to show that we can give them a better feeling that they can control their eczema. So these are 3 clinical outcomes we want to show. Yeah. Okay. Thank you so much.
Thank you.
Next we have Alim Matonga.
Can you imagine how difficult it would be if we cannot walk even for only a single day? Every year in the USA, there are about 70,000 people that cannot walk for months because they ruptured their Achilles tendon, the large tendon at the back of our calf. And most of these patients are relatively young and active, and they need to go through a rehabilitation about 9 months after surgery. If we can speed up the healing time, we can reduce their suffering significantly. And we have a technology that can cut about 20% of the healing time. Our technology is a kind of adhesive bridge to unite the ruptured tendon. The surgeons will like it because it's delivered using percutaneous method, which results in smaller wound and reduce the operation time by 60% compared with current method. So the advantages are strong repairment, fewer surgical complications, and faster procedure. And this can save the US healthcare system about $70 million per year. In addition, once it succeeds with Achilles tendon, it can likely be applied with other tendons and increase the market size by 8 times. We are seeking $2.3 million investment to conduct the clinical trial and regulatory process, and we aim to go to market within 5 years. So please join us and walk together in this journey. My name is Salim. Thank you for the time.
Rowan, would you like to go first this time?
Thank you, Jimmy. Very interesting, Aline. So one of the drivers for surgeons in this area is whether they can do more procedures in the same amount of theatre time and earn more in terms of fees per surgery. So have you any insight into whether this method would earn the same reimbursement codes as current technologies and approaches?
Yeah. So you're right. The value proposition of this device is faster procedure. So the clinician time will be more efficient, and we believe that the reimbursement code will be similar like other Achilles tendon rupture, because the code is general for Achilles tendon rupture treatment. But this is something that we will be discussed further with our regulatory advisor.
I think, Aline, that's a very powerful insight. We've all know that we've come through a pandemic, and access to elective surgery has not been as full as anyone would like, and therefore there are people awaiting surgery. But this is not an elective surgery, is it? It's an acute intervention when the Achilles has failed. Is that true?
Yes. When the Achilles is failed, and then the patient come to the hospital, and then the treatment will be done in the hospital. Is that answering your question? I mean,
I think that's a good answer. Thank you, Aline.
You're welcome. No worries.
Yeah, thank you, Ali. I think it's a fascinating area because of people of my age, I've known many people that have had a ruptured Achilles, and so any investor will see the opportunity. One thing that occurs to me, though, I can't think of any of my colleagues who've had a ruptured Achilles who've had an operation. You know, they've suffered, they've had these casts on that they've had for months, but I don't remember. Maybe they've only had a partial rupture, but how many of them ruptured Achilles need an operation? Do they all have an operation, or is it just some of them? And if it's some of them, you implied just now that it's done acutely, like the weekend. I always thought these things would be done semi-electively. In other words, following on from the point just made, is that it wouldn't be done in the middle of the night. It might be done a week later or a few days later, but semi-electively.
Okay, so up until now, there's no consensus what is the best treatment for Achilles tendon rupture. I think that's the opportunity for us. There are two most widely used treatment for current situation: non-surgery and open surgery. Non-surgery means no wound, but the tendon is prone to rupture. And open surgery, it provides a strong repairment, but it will cause the large wound site and several complication possibilities. So our device want to solve this problem. We provide a strong repairment, but much smaller wound.
No, I understand that. I suppose the question I had was, maybe I've just got it wrong end of the stick. Maybe I'm just confusing it partly with acute tendonitis of the Achilles tendon. Because I've seen many people over the years, but do all patients with an Achilles tendon rupture end up having surgery?
Not all of them, because if the Achilles tendon rupture happen with elderly, they will tend to not have the surgery.
Right. And what's the disadvantage you see of your system? Do you see any disadvantages?
The disadvantage.
Do you see any disadvantages?
Disadvantage.
Yeah.
Okay. So one of the thing from our device is there is a part of our device. This is the adhesive part. Only a small part of our device, but that's not biodegradable. So that will be always in your body. But this material is biocompatible, so it will save. So maybe this will be issue for some people, but we believe that will be fine, because we have tested the material is biocompatible, so it will be safe in human body.
Okay, thank you.
Okay, thank you.
All right, excellent.
Thank you.
Thank you.
Right, next up we have Joe Joseph.
Over 15 million people worldwide are living with metal pacemaker wires attached to their heart. Here at CardioFlex, we believe that metal is not the best material for pacemaker wires. It causes inflammation that can shorten the life of the wire, it breaks, and can lead to potentially life-threatening infections. If any of these happen, a surgery is performed to remove the wire and replace it. Patients that undergo this surgery endure long hospital stays, frequently experience complications, and are far more likely to have another infection and another operation. We have a wire that is made from a material that could reduce infection and lead failure by over 20%. It's a conductive polymer. This reduction would cut annual US expenditure on these surgeries by over $140 million. To help bring this medical device to market, we are seeking an initial investment of $5 million to bring the device through preclinical studies. At this milestone, we will then seek further investment to conduct pivotal human clinical trials and to seek regulatory approval in the US and the EU. This will enable us to capture a 20% share of the $4.7 billion pacemaker lead market that is growing due to an aging population. With your support, we can improve the safety of cardiac devices that are the lifelines for millions around the world. Thank you for listening.
Fascinating. And a very important area. Is it the wire that goes into the ventricle, or is it the wires that attach to the main wire that paces the heart?
Yes, it will be the wire that goes from the battery unit and inserts into the ventricle to pace the...
Okay. And with it being made of a polymer, I can see the advantages around infection. I get all that, and I can't see... I mean, it just seems such a good idea. I'm just trying to think of what are the downsides? Are there any downsides? Is it? Do you know how although it may not break, I mean, how robust is it in a biological environment?
Sure.
How can you test that?
So this would what the initial funding would be for, is to conduct animal studies to see how the wire would react within a live body. At the moment, we're conducting in vitro tests to see its cytocompatibility, and at the moment the results are looking positive. In terms of conduction, the wire is matching the levels of the current pacemaker wires. So the only downside I can see at the moment is that if it would fail at any of the clinical study stages. So.
Yeah, because you'd need to look at if the area was a low-grade infection, whether or not it could break that connection.
Mm.
Okay, I don't have any other questions at the moment. Sorry.
That's great. No, that's fine. Brilliant.
Joe, what proportion of pacemaker failures are due to wire failure?
So in terms of overall pacemaker failure, I believe lead failure is 40%, the rest being battery-related issues. But I believe that this conductive polymer will solve completely the lead fracture element, which would be 20%. and then we would conduct studies to see how much further of the other lead failures that this wire could solve, such as the malfunctioning of sensing, malfunctioning of pacing, as well as dislodgement. So this is what the studies would need to evaluate.
Okay. And I think there's kind of a number of different functions that you have to kind of evaluate in terms of biocompatibility. It's a fantastic goal, and it feels quite complex in terms of ensuring there's no ingress with tissue that the wire flows through, clothing effects. So can you talk a little bit about what you've done in vitro that might inform some of those risks and planning for the clinical trials design?
Sure. So at the moment we're doing an extract in vitro analysis. So we're analysing whether any small molecules are being leached from the material, which would then be cytotoxic. In terms of risk evaluation, there are substantially equivalent materials out there which have been proven to be cytocompatible. But given the novelty of this material and the novel composition of the various materials, we do need to reevaluate its individual cytocompatibility.
Just a point of information, I don't know what your material is, obviously, and I don't need to know, but in orthopedics, I was involved with a biocompatible fixation device where they made it flexible using plasticizers. And there was an observation that this improved bone healing. And they actually chased down the mechanism of action, and some of these plasticizers literally plasticize cells. So you actually drive stem cell de-differentiation.
Okay, sure.
Just something to think about.
No, absolutely, absolutely.
Excellent. Thank you. Next up, we have Donald Harmond.
Alice was left brain damaged when her blood sugar levels went dangerously low while still in hospital soon after birth. Alice was born 2 months early and weighed just under a kilogram. Preterm and low birth weight babies like Alice struggle to control their blood sugar levels. At the moment, to get a blood sample, clinicians pierce the baby's heel every few hours. But this method is painful and time-consuming. In the long run, if these extreme blood sugar levels go undetected, it can lead to a wide variety of long-term conditions, such as neurodevelopmental disorders, blindness, and as we can see in Alice's case, even brain damage. Our team here at Imperial College aim to provide a better detection method before the damage is done. These newborns can go through up to 16 painful procedures per day, and we have the potential to reduce that. Glucagon is our glucose monitor designed for use in babies. Not only does it allow continuous monitoring, but it does not penetrate the skin. The device can save an estimated 2 hours of nursing time each day while preventing avoidable blood transfusions. Glucagon has the potential to provide a painless alternative for Alice and other preterm and low birth weight babies. With your help and an investment of £2 million, this would cover clinical trials and regulatory approval initially in the UK, followed by the US. We can strive to give parents the peace of mind they deserve, reduce the workload of doctors and nurses, and give preterm little ones like Alice a warmer welcome to the world. I am Donald, and thank you very much for listening.
Brilliant. I believe you're on.
Thank you, Jimmy. And thank you, Donald. That was a great summary. So I'm interested here in terms of barrier to entry. So obviously there are some large companies out there looking at non-invasive continual monitoring of glucose. What have you got that they haven't? And how can you prosecute the opportunity as a result?
Okay, so a lot of the big players currently look into active sweat, but we are not monitoring active sweat, we're monitoring natural sweat. So this is a technological and competitive advantage we have over the big players at the moment. And as our device is also non-invasive, this is something that isn't currently out there in the market. So this is something, the unique advantage we have over our other competitors currently.
And therefore, in addition to the preterm and low birth weight baby market, I hate to use that word with baby, once you've proven the application, does this approach have wider applicability that would drive the value of what you're doing?
Yes, definitely. This can definitely be applied to the adult diabetic market, which is a very large market. So this definitely has the potential to go to this market after we've trialed it in neonates. And also the device can also detect other analytes such as lactate, which will be used for identifying sepsis.
Great answers, thank you.
Can I just, thank you. Can I just follow on from Ryan's question about, because I just the other day I saw an advert about people having their blood glucose being monitored. Never need to do any more skin pricks, continuously monitored, just all the insulin. And I don't understand quite, you said about natural sweat rather than active sweat. I don't really understand why your device is different from theirs. Mainly they'll be looking at high blood sugars, whereas you're looking at low blood sugars and in neonates. What is it that's different about your technology compared to the technology that already exists, is well developed, already on the market? I don't quite understand that.
So currently on the market, there's actually no non-invasive devices. They're minimally invasive. So the needle is roughly 0.5 millimeters in those devices. So they're characterized as minimally invasive, but we are actually non-invasive, so we do not penetrate the skin whatsoever with the technology that we have.
Right.
Does that answer your question?
Okay. And again, I suppose extending Rowan's question, in what other way can you extend it beyond just monitoring? Because obviously monitoring neonates is quite a limited market. And how could you extend that market?
Yeah, so
using the same technology.
Yeah, so as I said before, we can also use this in adults, which will create a much wider market, especially in diabetes, because currently even in the adult market, there's no non-invasive devices that can do the same thing. So we can extend this toward diabetes in the adult market.
So your view is that this is much more socially acceptable to even adults because there's just no discomfort at all?
Pardon? Because
there's no discomfort.
Oh yeah, that's definitely one reason, but also yeah, there's no discomfort, and the technology that we have, it allows continuous monitoring, but we're going to create in a way that has high sensitivity. So at the moment, a lot of devices are inaccurate below 2 micromolar. So we're essentially trying to create a device that's also sensitive, very sensitive below 2 millimolar, which is the hypoglycemic level in neonates.
Okay. And you think people would pay for this really mainly to avoid pinpricks to babies, really?
Pardon?
The main driver for someone to buy this product is to reduce the number of pinpricks that a baby has, is being actively monitored.
Yeah.
Is that right? Okay.
Yeah.
All right. Thank you.
All right. Thank you, Donald.
Thank you.
Thank you, you, Donald. Next up, we have Sam Brizo.
Christopher is a young cyclist training for a race. While training, a driver lost control of his car, hitting him and throwing him into the air. When the ambulance staff arrived, they quickly realized he would need nearly 100 pints of blood for his recovery. To put this into perspective, this is 10 times the amount the average adult has flowing to their body. Thankfully, Christopher survived. But this happens every day. Blood loss is a common cause of death among all ages, and even the main killer in under 40s. A lot of these lives could be saved through better wound care. Unfortunately, the majority of products are ineffective. They take a long time to stop bleeding, and their removal can reopen wounds, leading to unnecessary blood losses. Here at Imperial, we're developing a unique technology that can address all these issues. Our innovative wound dressing ensures a rapid halting of blood loss, and as it does not stick to the wound, it is also very easy to remove. It is also antibacterial, reducing the likelihood of infections. Injuries are just a fraction of a $700 million market across acute wound care in the United States and the UK. The benefits our dressing provides can improve clinical outcomes in hospitals, especially during complex and invasive procedures. Our wound dressing can help close surgical incision neatly and rapidly. With further development, we even hope to address chronic wounds such as diabetic foot ulcers, raising our addressable market size to over $2 billion. To make our technology a reality, we need your help. We're looking to raise $1 million to fund our clinical trials and biocompatibility testing, and eventually launch our product. We hope you will join us on our journey. Thank you.
Again, very interesting. Without revealing any of the intellectual property, can you say how it works?
Of course. So we actually have a Pct patent, so I can give you some detail, but not too much.
Yeah.
But we effectively have discovered by chance we were looking to develop something that would repel blood and stop thrombosis, but instead we realized it would actually induce thrombosis, and it's a coating made from PDMS and carbon nanofibers. At the moment, we're trying to really understand the mechanistics as to how it works and how it interacts with the clotting cascade, but this is the current testing going on, but we know it's very effective at clotting blood.
And will that only therefore work on superficial wounds, or will it work on deeper wounds? Because obviously I'm not sure your example is the best example you could come up with, but because obviously a patient's traumatized bone, but if you've got a severed vessel, how, or something where you've got major blood loss, I'm not quite sure how I can see how it can work for superficial wound care and bleeding, and I can see how it can be really useful in the hospital. But in the scenario that you portrayed, I didn't really quite get it, because I think if you've got a major bleeding vessel, I can't see how it would work.
So something I've not mentioned in my pitch is that another benefit of our product is that it actually stops blood seepage, because our product is actually hemophobic. So because of this property, that means that we can withstand very high pressures of blood without blood seeping out of the vessel, which is why we believe this is actually an ideal product for cardiovascular and for the cardiovascular space. Regarding what you just mentioned and deep wounds, we actually have an eye-to-eye application right now to optimize the product for this specific application and create a version that would be suitable for deeper wounds than what we currently have.
Very well answered, thank you.
Really?
So Sam, my observation here is this is a hugely difficult market. I think the last time I heard someone talk, there were over sort of 120 different dressings in the NHS for various types of wounds and surgical activities. So it's a very crowded market. And to the previous point, I think your use case might be better served with things like battlefield emergency dressings.
Yeah.
Two reasons. One is there is a ready appetite to invest in better technologies, and the military, both in the UK, US, Europe, will invest in these technologies. So that's just an observation. Having said that, if it works, it's really powerful because, you know, if you look at things like the blood service, they're always struggling to find more donors, and managing supply of blood is challenging. So anything that addresses that is really attractive. So can you talk me through the development plan for how you characterize the unique benefits of the material to inform your product profile?
Of course. So first of all, let me just preface by saying it's an absolutely valid point. Wound care is a very crowded market. I think we need to think about this in a more holistic manner. Our product has a unique USP, which is not that it stops bleeding quickly. There are other products that do that. But it's the only product that does not stick to the wound site. So it means if you have a lot of blood loss, you can easily remove it after its use. Now, talking about the battlefield injuries, there is a product out there that's currently used, and it's pretty much the leader in this space. However, from our conversations with military doctors, one of the biggest issues is that this dressing is very stiff, and therefore it's very hard to manipulate. Now, because we're just applying a coating onto a standard gauze, we don't actually face the same issue because it's not impregnated into anything, and therefore we can actually improve the medic's experience with using our dressing. Plus, we have the other benefit I already mentioned of not sticking to the wound. In terms of our development plan, we are, right now, we're trying to really characterize how well we are comparing against the competitors in terms of hemostasis and hemostasis time. We know we're better in the control, so like a standard gauze, but we also have like strategies in place as to what our next V2 is going to look like and how we can improve hemostasis going forward while not compromising the other properties that make our dressing unique.
And I think my other question for you is price. Is it too early to give any indication as to where you think the price point would be for something like this?
Of course. So I've done a few calculations based on what it would cost us to make it in the lab. And in terms of material cost, we are talking around 40p, but I believe with industrialization, we probably can bring this down to 25, even less potentially. Looking at the US reimbursement for wound dressings, we are talking about 2.38 to 2.86, I believe, dollars per 10 centimeters squared of a dressing. So we can really have a really healthy margin, assuming we can industrialize this to scale. So we're talking about almost 90%.
Thank you, Sam. I think you need to add to that the cost of manufacturing in a regulated environment, but I think that's persuasive.
All right, excellent. Thank you, Sam.
Thank you.
Thank you.
Next up, we have James Young.
So, when you want some help, you might say, please give me a hand, without thinking twice. We always take our limbs for granted. However, there are nearly 1 million population in the world suffering with the problems of hand loss. And that number is estimated to be double in the next 2 decades. And all of them need us to give them a hand. You've probably seen some novel robotic bionic hands that are designed to provide users with functional or rehabilitating supports. However, these products are always not fully optimized to complete frequently daily use, as many of them could be too heavy to carry or just not easy enough to control. And most of them can cost at least tens of thousands of dollars. All this have made users feeling annoying and abandoning their products after using several times. So to meet the needs of these devastated users, we are now developing the Imperial Arm as a smart robotic bionic hands from the scratch, which we believe it could be the balance of low cost and high performance. Our product is designed to have sufficient motions of numbers to support a frequently daily use. And the adjustable socket is here to ensure comfortable and reliable on our users' residual stumps. More importantly, with our sensation feedback system, the device will bring our users back their sense of touch. My name is James, and I'm the CEO of Imperial Arms. We plan to launch our product to pre-production phase in the next 2 years, and then make it commercialized by 2025. We want to raise £1 million to complete the current early stage prototyping, as well as finish the clinical trial. Please give me a hand. Thank you for listening.
Rolling.
Thank you, James. That was really a great overview. I've had the privilege of sitting in and listening to a number of the students on this course over several years, and I've heard about this problem multiple times. So it's a really hard problem to solve. When you speak to potential users of these devices, how do they break down? Do you think, if I might be slightly crass, one device will fit everyone's needs? Or can you talk about the types of different needs that you encounter when you talk to patients?
Well,
it sort of speaks to how the market will segment.
yeah, thank you. So I think the biggest needs of the patients, of the amputees at the moment, is that they want to, by mentally, they want to look natural as a normal human being. So the out-shape design of our device could meet these requirements, because we have very beautiful and natural shape designs. And talking about the functionalities, we have developed grabs, pitch, and hook, these gestures to facilitate their daily use. And the system is relatively simple compared to the other competitors, and it would lead to our product more robust and easy to use.
And a second question is what do you think the healthcare providers are willing to pay for an effective device? So what's the target market price?
Yes, talking about the final market price is still uncertain at the moment, but we have conducted a very brief market analysis and competitors research, and the average price of the close competitors is hovering around $30K US to like $80K US, which was a little bit higher to a normal amputee. And we believe we can cut our price down to $10K US based on our development process.
Thank you, James.
Thank you.
Thank you. James, I just wanted to get a bit more from Rowan's question really about the use, because I suppose your answer implied it was more cosmetic rather than functional, you know, because it's about the look and about being able to gesture. Whereas I can imagine somebody, you know, in many ways would want to be able to, you know, little things like get cash out of the cash point or put a petrol cap on the car. What are the things, have you spoken to people to find out what do they actually need and want? Or have you imagined what you think they need?
Yeah, so we are now cooperating with amputee in our lab, and his name is Chrono, and he's very supportive. We have did some trials with him with our early stage prototyping, and he said he really loved it because our device has a very good external shape design, and also we have a very good multiple degrees of freedom simultaneous control, and he used it very well. And we just calculate the time that he used our prototype to finish a particular task and compare it to he using his the bionic hand that he's now using is one of our close competitors, and our performance of the prototype is slightly better. I mean, the time that he used is slightly faster.
Okay. But have you done any questionnaires of people that have lost one hand and find out what things they can't do, like driving a car, you know, because they can only use one hand? I don't know. I mean, have you, because understanding that those problems, so you can really focus on making sure that the solution fixes the problem that the user experiences, which is key, I think, isn't it?
Yeah, you're definitely right. I think that would be the next step of our development. We will go for some charity centers and get in touch with more samples of amputees and to help us to improve our future design.
Okay. And did I hear you say it can make you feel touch?
Yeah.
How does it do that?
Yeah, so in brief, we are now developing a novel detector, a sensor, which will be integrated on the surface of the bionic hand. So when the product touches the object, it will provide some stories on the sensation of our amputees' residual stumps. But due to we haven't filed or applied any patent yet, so we will be very happy to talk to you the detail if you make non-disclosure agreement. Yeah.
Okay. Thank you.
Thank you.
All right, thank you, James. All right, thank you, James. Next up, we have Celestin de Neverful.
Before his 15th birthday, Dylan died from a treatable disease. He was in Evelina Children's Hospital, just here in London, but yet no one could have detected it. But today we can. In fact, we could have saved his life. We are developing Ninja Diagnostic, a tool to detect the Kawasaki disease, the condition which Dylan died from. In Europe, almost 100,000 children are impacted every year. There is an efficient treatment, but misdiagnosis is common and could be lethal. The problem comes from the complex gene signature that makes his condition very hard to detect, but our patented technology can read it. We can have a profound impact as there is currently no available test. And moreover, this is a platform technology that could be used to detect other conditions, like prostate cancer or even sepsis. Our bioengineered liquid is compatible with standard hospital equipment. Unlike current practices, it does not require any external lab. This integration saves critical time, is cost efficient, and it transforms existing machinery. We have promising results, but we need your help. We are now looking for £500,000 to complete our preclinical studies. My name is Celestin, and we are working to see Ninja Diagnostic in hospitals, preventing avoidable death, just like Dylan.
Thank you very much. Yeah, as you say, Kawasaki disease is a devastating disease for many. We can sequence the human genome, and gene sequencing, which in my early days was very difficult to do, is now easy. I'm not quite sure what your technology is offering over above anything that we could do if we applied ourselves to it using existing technology. What is special about what you've got?
Yeah, sure. Indeed, if we imagine a world where it would be almost free and we could sequence within minutes, then a lot of diagnoses, a lot of methods wouldn't be useful at all. But at this point, most of the hospitals, they don't have the sequencing machines. They have to send samples somewhere else. It's expensive and it takes really a long time, especially for diseases like Kawasaki disease, where you cannot even afford like 1 day or two. So the current methods to detect those genetic signature would be indeed genetic signature or DNA microarray. But with our technology, compared to those, it could be made within the hospital lab using existing machinery, which is a real-time PCR machine. So with that, it's much cheaper if you do sequencing or DNA microarray. You have to use PCR like as a first step. So compared to those, it could be made on site. Yeah.
Okay, but if you're using PCR technology, you have a sequence that you use to start the polymerase chain reaction. What's just to stop anyone else just doing similar technology? You've got a product which might be very good at diagnosing Kawasaki, but what's to stop someone else doing it, given the fact that the human genome is already out there, published, etc.? I'm not sure what you're bringing to the table that's unique.
Yeah, sure. Well, to prevent other competitors, like a barrier to entry. So obviously we do have a patent, but that wouldn't prevent someone else to indeed detect the genetic signature with sequencing, for instance.
Yeah.
So it's important to mention that genetic signature could be also patented. And the genetic signature for the Kawasaki disease is also patented by Imperial College. So that's a first answer. And other people could do that too, but they would need to use sequencing. And compared to them, the cost of production for us is only a few pounds. And as I said, it could be made in hospitals. So because it will be faster and cheaper, we will be highly competitive. And also, you don't need to do a whole sequencing. We just look for the genetic signature. You don't need to do the whole sequencing for that. So that's our key advantage.
Yeah, I suppose I was just thinking, why can't someone else copy your primers and then just replicate your technology? So that's not there.
Yeah, sure. Well, indeed, everything we'll be doing.
Well, I'm not talking about commercially, but I'm just thinking if I was, in a lab, we can, you just buy a primer, you just run the assay. It's quite easy to do.
Yeah, but then the key technology for us, it's the whole engineering of all those primers. So it's a competitive amplification network. So all the primers, all the reagents are organized in such a way that
you've got a number of different genes that you're looking at together which make up Kawasaki.
Exactly. And then
okay.
But then the key things for us, it's we only run one single PCR. We do just one run.
Okay,
with
got you.
all the genes at the same time. So it wouldn't be that easy to replicate because we have the whole
I
liquid.
understand now. Okay,
Yeah.
sorry.
Thanks for the question.
Thank you. Raleigh.
So Celestine, I think this is really interesting because it speaks to what we're going to be doing in diagnostics. So I think I'm slightly troubled by this application in that in the UK we've just announced that we have plans to sequence every newborn. And so you would imagine that you could detect future risk of Kawasaki at birth. In which case, the market doesn't look that great for what we're talking about. But I think it comes back down to two other factors that are sort of beyond just the technology. Firstly, it's what parents actually want to know about their newborn. And Chris Wigley was, who's CEO of Genomics England, was telling a very thoughtful story. They'd gone out to speak to parents of newborns about what type of information they would like to know as a result of sequencing their child. And there was a very telling story from a mother whose child had Duchenne's. And the Duchenne's obviously didn't become apparent till beyond the first year of the baby's life. And Duchenne's, unlike Kawasaki, is not treatable. And the mother had said she wouldn't trade the first year with her baby for the knowledge of that disease at birth. And so I think that's a very sort of social challenge around these diagnostics that I think is a really important conversation to be aware of in terms of the market, your technology. And the second piece, if I might be so bold, is yes, of course, in university labs, we can whoop up some primers and do PCR, but we do want standardization of diagnostics in our clinical diagnostic workflow. So I think somewhere between that, there is the opportunity for tests like yourselves. I'd like to sort of explore the extensibility, though, of your platform. Is it that you can do PCR around multiple genes simultaneously? Is that really part of the opportunity?
Yeah, that's exactly the point. So we could run one PCR cycle to try out like all the genes at the same time. For the Kawasaki disease, we're talking about 13 genes, and obviously for cancer, there is a lot more genes involved. But if your question was about how we could develop that for other conditions in the future, right? So at first, this technology was developed to diagnose tuberculosis. So for that, there is 4 genes involved, and now we are adapting the technology to the Kawasaki disease with 13 genes. And one of the reasons why we're not going straight to breast cancer, for example, there is Mamaprint, it's out there, but they're looking for 70 genes. So we will get there, but Kawasaki disease is the first great step in terms of like technical development.
So, do you envisage building a platform, or is your business essentially reagents, diagnostic reagents?
Well, the technology is a platform that we will continuously develop in the future, but exactly our product will be the reagent itself. So
can I just clarify that? Is that a hardware platform? So would a clinical diagnostics lab have to invest in a new hardware platform? Or would they be able to run it as a cartridge in an existing clinical diagnostic platform?
Yeah, that's one of the key advantage of our product, because clinicians, I mean the hospital labs, they will just need literally the vial, like just the liquid to run the PCR, and then the readout is going to be extremely simple, and most importantly, the readout will be completely integrated within any type of real-time PCR machine. So we really thought about that integration in the hospital labs, and we took that into consideration for the development.
So how many labs and how many tests do you imagine running in a year?
So in a year, what we need to do now, we would like to test that diagnosis on blood patients. So we are thinking about 20 patients, like 20 controls and 20 patients that, infected blood from the Kawasaki disease. That's our, that's the proof of concept we would like to develop.
Okay. I think that's all my questions at the moment. I think I'd like to have a really longer discussion with you, but I think that's a good point to stop.
Yeah, I'd love to continue the discussion. Thank you very much.
Thank you.
Excellent. Thank you, and congratulations to all the students. You've really done wonderfully. I'm impressed every year, but I don't think we've ever had this consistent high quality from the presentations and also with the question and answer. So thank you all the students. And if you can just join us virtually, but we'd like to give a round of applause to all of our great students here today. Excellent. Also, I would like to thank our panel, Kevin Moore and Rowan Gardner. Fantastic questions, great interaction, wonderful advice and input for the students, and I can't thank you enough for your time with them today. Let's give the panel a round of applause as well. Excellent. We'd like to invite you now out there, wherever you are, to join in an opportunity to interact with our students. We are going to be posting a QR code and also a web link for you to join them in individual rooms connected to them in a way that they've arranged themselves. I'm not exactly sure how it's going to work, but if you go to the code, to the web link, you'll find that there. Thank you all for joining us this evening. We appreciate the interaction, even if it's just one way. We look forward to hearing from you. You can contact me through Imperial College if you can't track the students down this evening. But thank you again for your attention, and have a good evening.